You know, we've seen data, and we're going to talk about sequencing these drugs, right? But both these studies were done in patients. When I say both, I mean the development of sorafenib, the development of lenvatinib was done in patients who had preserved liver function. You know, there's clinical research which proves a concept that the drugs are active, that they change outcome, and then there's clinical practice, right? And I think one of the things that us in the academic arena are concerned about is we're getting all these new drugs, but are patients in the condition to maximize the benefit from them? And what do you do for patients who have diminished liver function? Are you offering them either drug? Does it weigh into your decision? Is it any treatment versus no treatment?
Yeah. It's a very difficult question, again, and a lot of clinical judgments are involved. When we say diminished liver function, there's a whole range, right? There's the patient, as I noted earlier, who has really decompensated cirrhosis with ascites requiring paracentesis, active encephalopathy, more in the BCLC-D category, and these patients should not have their cancer treated. I mean, at this point, we don't know that any cancer therapy would be tolerable, and that any cancer therapy is going to extend their survival in a meaningful fashion, because their mortality is more likely to be driven by their underlying liver disease. Patients in the intermediate liver dysfunction, meaning patients who have slightly elevated bilirubin, low albumin, are manageable on diuretics, not requiring active paracentesis, probably are patients who may benefit from some cancer therapy. And this is where the extrapolation happens. Now, when we talk about sorafenib and lenvatinib in let's say Child-Pugh-B, I don't think one can choose one or the other based on any scientific data. We have more experience with sorafenib so far with registries and some data in Child-Pugh-B patients, not randomized data, but at least some safety data. With lenvatinib, hopefully that will emerge over time. But really, it comes back to clinical judgment for these patients.
So we have two drugs in Frontline. We talked about the importance of getting patients in good shape before they've gone through extensive local regional treatment. You know, yttrium-90, just in closing on this Frontline discussion, you know, that's another local regional approach. It's been looked at pretty extensively in intermediate disease, you know, in the context of patients who are TACE appropriate, but in the context of systemic treatment, there's been a move by some to say, well, you progressed on TACE, and instead of going to first-line lenvatinib or sorafenib, I'm going to do another Y90. What can you sum up about the recent data with Y90 versus systemic treatment?
Yeah. I mean, I think we can go to the recently reported trials, the SARA and the sorafenib studies, which both compared Y90 versus sorafenib for patients with quote-unquote advanced disease in the liver, no extrahepatic metastases. And both of these studies were negative, both in the intent to treat population as well as the treated per protocol populations. So the studies were designed to show the superiority of Y90 over sorafenib, and they were negative in that sense. Whereas there's a danger a bit is in the interpretation that these studies may show that Y90 is not inferior to sorafenib, but that was not the intention or the design of these trials. And I think that would be a misinterpretation of the data at this point.
So in Frontline, it's exciting. We have options. Obviously, how we decide which drug to use, I think we're still evolving those paradigms, and we'll look forward to further analyses to help guide us a little more rather than expert opinion, but some data-driven approaches.
Absolutely.